My name is Sandy Sachs. I am one of the cancer pain doctors over at UCLA. And today we'll be talking about how to effectively manage cancer pain. So hopefully by the end of this workshop, you'll be able to list why some of the different causes of cancer pain, the different categories of cancer pain, and also be able to just apply the basic steps. And I'll go more into this on how to manage your cancer pain. And then most importantly, I hope that you'll feel comfortable approaching your healthcare team with any concerns on your pain control. So I just want to start off by saying the diagnosis of cancer, especially advanced cancer, can trigger enormous distress. You or your loved ones in this situation not only face the burden of physical suffering, but also the threat of losing your independence, impending mortality. You often have to make very difficult treatment decisions that can have life or death implications, all the while navigating a very complicated healthcare system. So cancer pain is one portion, but it is a very significant part of an overall bigger picture. And regardless of cancer type, one of the most feared symptoms that patients report is pain and the fear of dying in pain. But I want to reassure you that having a cancer diagnosis does not necessarily mean you'll have pain. It is often present. 25 to 50% of people experience moderate to severe pain, especially in the advanced stages, but it can be managed with medications, radiation, and other treatments. And pain is subjective, so each person's experience of pain is going to be different, and everyone needs an individualized pain management plan. Even if you have the same diagnosis or the same type of cancer as someone else you might know, your pain management plan can look very different. I wanted to share this quote with you. Pain is whatever the experiencing person says it is, existing whenever and where the person says it does. This was said by Margot McCaffrey, who was a nurse, a leader and pioneer in pain management back in 1968. Like I just mentioned, pain is a subjective experience, so no two people's pain perception is going to be the same. So it's very important to develop a pain management plan that is unique to yourself. When pain is under control, you can focus on other things. And without good pain control, it can really overwhelm every aspect of your life. It can affect your mood and affect your relationships with your loved ones. So what causes cancer pain? And when I describe cancer pain, I refer to pain that cancer patients tests, getting a biopsy, a bone marrow test, a spinal tap, those potentially cause pain. But don't let concerns about pain stop you from having tests done. Talk to your doctor ahead of time about what steps you can do to try to lessen any potential pain. When we think about cancer pain, we often think about the second category, pain from the actual tumor itself, compression on muscles, bones, nerves, spinal cord, and organs. But pain can also come from treatment. So chemotherapy, I think the biggest one is chemotherapy-induced peripheral neuropathy. You can also get pain from radiation, and you, of course, can have pain after getting surgery for your cancer. If you get a resection of your tumor, you can have post-surgical pain. Then there's pain that is unrelated to your cancer that my patients often experience. And this can be arthritis, migraines, low back pain. Maybe they haven't had much chronic pain in the past, but I often tell patients that when you're undergoing cancer treatment, when you have a cancer diagnosis, your lifestyle also changes. Many people are not as active as they previously were. They may have lost weight, they're more sedentary. All of this can lead to increased aches and pains from non-malignant reasons. So I try to reassure patients that not all pain when you have a cancer diagnosis is necessarily related to your underlying cancer diagnosis. So I want to move on to categories of pain. I like to divide this into two categories: nociceptive pain and neuropathic pain. Nociceptive pain is pain caused by injury to body tissues. So this could be in your musculoskeletal system, on your skin, cutaneously, or visceral, so abdominal region. And then there's neuropathic pain. So this is what we refer to as nerve pain. Pain that is caused by a lesion or dysfunction in your nervous system, either the peripheral nervous system or the central nervous system. You can also have mixed pain, where you have a combination of both of these types of pain, features from both. Nociceptive pain is further divided into two categories: somatic pain and visceral pain. Somatic pain is described as localized, well-localized pain. So if you bang your knee, stub your toe, you have a metastatic bone lesion somewhere on your hip, and you can really point with one finger where that pain is, that's usually referred to as somatic pain. Then there's visceral pain, and that's that vague abdominal pain where you can't really point with one finger to exactly where that pain is, but it is a type of nociceptive pain, often occurring in the abdomen. Neuropathic pain is what we refer to as nerve pain. So patients often use a few adjectives to describe nerve pain when they're experiencing it: stabbing, shooting, pins and needles, burning, electric shock-like, tingling. It feels numb, but a painful kind of numb. CIPN refers to chemotherapy-induced peripheral neuropathy, and it's often related to several types of chemotherapy that you might have heard about and maybe you've even received. Taxanes include paclitaxel and docetaxel. Platinum agents include chemotherapy like carboplatin, cisplatin, oxaliplatin, and vinca alkaloids are chemotherapies like vincristine and vinblastine. In general, these respond poorly to opioid medications and usually responds better to nerve medications, or what we call neuropathic agents. CIPN, or this peripheral neuropathy related to chemo, can be really debilitating, affect the quality of life, and it can affect the chemo doses. If you're not able to tolerate a certain level because of the side effects, your oncology team might have to decrease your dose or dose adjust, which can affect the amount of chemo that you're receiving and the effective amount that is working on your cancer. Next, I want to talk about different types of pain. You'll often hear these different terms: acute pain, chronic pain, breakthrough pain. Acute pain refers to pain that comes on quickly, lasts for a short amount of time, and then goes away. Chronic pain refers to mild to severe pain. You can have a mild amount of chronic pain, or you can have severe chronic pain, but it persists over a long period of time. And that period of time is can be really variable. Usually we say, at least 3 months. Some people might say at least 6 months, but it's basically pain that is constantly there, that doesn't go away. But you can, on top of your chronic pain, have breakthrough pain. So this is severe episodic pain that occurs often multiple times throughout the day. So I wanted to introduce you to this 3-step analgesic ladder. This is something that was put out by the World Health Organization back in 1986. It has been used for cancer pain and validated for cancer pain patients, and really shouldn't be used for chronic non-malignant pain. And so for patients who have chronic back pain but don't have a cancer diagnosis, their physicians and healthcare teams really shouldn't be using this ladder to treat their pain. But where we start off is at the bottom step, using a non-opioid medication, such as Tylenol or over-the-counter NSAIDs like ibuprofen, Advil, Aleve. One thing to note is that NSAIDs can be really helpful for bone pain, but sometimes we're limited in its use if patients have any sort of kidney disease, if they're on a blood thinner. If you have a blood clot, you're on a blood thinner. These medications, NSAIDs, can also thin the blood, so it can interact with your blood thinner. We usually tell patients not to use it. Or if they've had prior gastric ulcers, we also want to make sure that you're not using these medications, as they can increase your risk of having an ulcer. If that doesn't work, you can go on to a weak opioid, and that consists of Tylenol with codeine or Tramadol. And if that doesn't work, you move on to a strong opioid. And those strong opioids, I will go over specific types of those, but they include things like morphine, Norco, Percocet, oxycodone, Dilaudid, fentanyl, all the ones that you normally think about as an opioid. Those are all considered strong opioids. I just want to mention that you can combine a non-opioid with a weak opioid. You can combine non-opioids with a strong opioid. You shouldn't be mixing different types of opioids, though, unless your doctor tells you so. And then along each step, you can see with or without adjuvants. So adjuvants can include things like nerve medications. It can include things like steroids. It can also include muscle relaxants or any topical options like lidocaine patches or Voltaren gel to help you with your pain. So I wanted to talk about specific types of medications that you might have heard and give you a few tips on how they might work, how to take them safely, and side effects to watch out for. So for nerve medications, if people have neuropathy, if you have nerve impingement, if you're experiencing pain that fit any of the adjectives that we previously talked about, stabbing, shooting, tingling, your care team might recommend that you use a nerve medication. So the three main categories that I like to divide this into is one, gabapentinoids, and the two medications in this category is gabapentin, also known as Neurontin, or pregabalin, also known as Lyrica. The second category are SNRIs, which is serotonin norepinephrine reuptake inhibitors, and the most common one we use for pain is duloxetine, also known as Cymbalta. And then TCAs, which stand for tricyclic antidepressants, and the medications for these are amitriptyline, nortriptyline, imipramine, desipramine. So you'll notice that, in the second and third categories, these are often used for mood as well. And so those two categories in particular may interact with any antidepressants. So if you're on an antidepressants or anything that interacts with serotonin, talk to your healthcare team about how you should take these medications. And many of these medications can also cause side effects like drowsiness, dizziness, and changes in your mood. I wanted to spend some time talking about opioid medications. I wish that there were better options to treat severe cancer pain, but unfortunately, opioids are still our mainstay of treatment when patients have really severe cancer-related pain. The two different categories of opioid medications are short-acting medications and long-acting medication or extended-release medications. Short-acting medications are usually what you start off with. So when you start having severe pain that is not controlled with Tylenol or ibuprofen, your care team may recommend using Norco or Percocet. The mild opioids, Tramadol and Tylenol with codeine, are also options. Short-acting medications are also used on top of extended-release medications if those are prescribed. Long-acting medications include things like MS-Contin, which is extended-release morphine, OxyContin or Xtampza, which are versions of extended-release oxycodone. Fentanyl patch, you may have heard of, is considered a long-acting or extended-release medication that goes on your skin and is absorbed slowly and changed out every 72 hours or 3 days. Methadone is another extended-release medication, and then there's also a version of extended-release hydromorphone or Dilaudid. The key thing to note about these two types of opioid medications is that short-acting medications are typically used as needed, and long-acting medications should be taken as scheduled. So oftentimes the MS-Contin or OxyContin, they're dosed 2 or 3 times a day, it's important that you take it every 12 hours or every 8 hours if you're on it 3 times a day. What it does is it helps with decreasing your baseline level of pain. So rather than chasing your pain or treating your pain with a short acting that works quickly, the long acting medications really bring down your level of pain. So if you're chronic pain, you live at a level of 6, and sometimes you have these breakthrough pain episodes that spikes up to a level 9 or 10, using a long-acting medication may bring down your baseline level of pain to a 3 or 4. You'll still have those spikes of breakthrough pain, but they'll be more manageable than it was before starting a long-acting medication. So I wanted to show these 2 graphs here. This is a short-acting versus long-acting opioid medication. If you just have acute pain, so the pain comes on once a day, a couple times a week, you use a Norco tab and it goes away, this doesn't necessarily apply to that situation. But let's say you have severe pain that's there all day long. One of the first things that your doctors might recommend is start taking your short-acting around the clock. So every 4 hours, take a Norco or take a Percocet and see if your pain is managed. And if it isn't, then they might actually recommend starting a long-acting opioid medication. But I just wanted to draw your attention to the graph on the left. So in a short-acting medication, if you're taking it every 4 hours, what is happening is that the level in your blood, so the serum level of that medication, is going up and down. And because it acts quickly, it's a short-acting medication, you're actually also going to be reaching some side effects, more so than a long-acting medication. The pain relief lasts for a short amount of time, and then it goes away. You have to take another dose, and this cycle repeats itself. When you start a long-acting medication, it does take a little longer to reach the level of pain relief, but it also lasts longer. So you can see in that middle section, you have a longer period of time where you're spending in that pain relief zone before it comes down again. And then the key thing to note about this is that because it takes a longer time to reach pain relief level, it also takes a longer time to come down and leave your system and be metabolized. Long-acting medication should only be started if you've tried more frequent short-acting medications and it isn't helpful. You'd never want to start a long-acting medication if you've never even tried a short-acting medication because it can be really dangerous. So opioid naive, meaning you haven't been on opioid medications, you don't want to immediately start a fentanyl patch or MS-Contin or methadone if you haven't tried things like Norco or short-acting morphine or Percocet, Oxy, those kinds of things. So some of the side effects, common side effects that we see with opioid medications is nausea, constipation, itchiness, drowsiness, decrease in your breathing rate, and impaired motor skills, thinking, or judgment. And when you're dehydrated or drowsy or suffering from fatigue from your cancer treatments, these side effects can be further magnified, especially constipation and negative cognitive effects. So I would say that one of the most concerning side effects that I hear from my patients all the time is constipation from these medications. There are multiple different types of laxatives, and some of these are available over the counter. Oftentimes, my patients will say, is it okay I've been on fiber products or psyllium or methylcellulose, can I continue these? In general, if you're staying very well hydrated, yes. But the way that these medications work is just that top bulk forming class is that they draw water out from your system, from your body, and it basically forms a larger bulk of stool. And you can see how that might work against you if you're not well hydrated, or even if you have abdominal pain from your constipation. Now you just have a large amount of stool sitting there. Opioids, the way that it causes constipation is that it slows your gut down. And if you have a larger bulk of stool from these products, these fiber products, it's not really helping the reason for your constipation, which is that the stool isn't moving forward. So I usually recommend using motility agents. So using things like Senna, Miralax, you can use lactulose, milk of magnesia. I also wanted to mention stool softeners. So the common one over the counter is Docusate, also known as Colace. It's often used in combination with the other two categories, osmotic or stimulant laxatives. On its own, it only softens the stool, so it doesn't help with movement, which is the main issue with opioid-induced constipation, is that your bowels aren't moving forward. So Colace on its own won't necessarily address the issue. You often have to use it in combination with an osmotic or stimulant laxative. I often hear patients, their biggest fear is constipation with opioids. And sometimes they run into issues where the constipation is so bad, then they overdo the laxatives, end up having really severe diarrhea, and become fearful of using opioid medications to treat their pain. What I like to tell my patients is that if you're going to be even on one pill of an opioid medication every day, you need to be on some sort of laxative, even if it's a really small amount. It's better to stay on top and find a good regimen to keep your bowels regular than play catch up. So you don't want to run into that situation where you wait to take laxatives until you're too constipated. You'd rather take like a half a cap of Miralax or just like one pill of Senna a day, just to keep things as regular as possible. I also wanted to talk about Narcan, and you may have heard about this just from the media or seen posters around it, or your pharmacy might have recommended that you have a prescription of Narcan when you pick up your pain medications. And it can be a very scary topic to discuss, but it's very important. So Narcan is an opioid reversal. It's only used for emergencies. It's not something that you're ever going to use on yourself if you're the patient, but you should have it at home and your family members should be educated on how to use it. Essentially, if you stop breathing, someone is going to spray Narcan in your nose and immediately call 911. It's going to reverse all of the opioid receptors. So if your breathing has slowed down or stopped completely, it will help with that specific symptom and help. But just keep in mind that because it reverses all the opioid receptors, if you are on opioids for pain, likely the pain is going to be severe for at least a short amount of time until the Narcan is metabolized through your body. So after talking about all this, I do want to say that some patients may still have severe pain despite all of these different medications that we talked about. For the most part, 90% of patients are going to be fine with medications alone, but about 10% of patients may need something additional. So this fourth step includes nerve blocks, epidurals, pain pumps, spinal cord stimulators, and again, not everybody will need something like this, but just know that there are options. If you have severe side effects from pain medications or don't want to be on pain medications for your own personal reasons, talk to your healthcare team. Maybe you need a referral to an interventional pain doc and see what other options exist. Radiation is one option to help with pain, and this doesn't necessarily fall into that ladder that you just saw as a fourth step. If you have pain, talk to your oncologist and see if radiation is an option, because it can be really helpful. It's not without its own side effects, but in a lot of cases, it can greatly reduce the level of pain that you're experiencing. Nerve blocks. So this is something that I often do for my patients. When we think about cancer-related nerve blocks, the celiac plexus block is what has been shown to be most helpful. And this is not a nerve block that everyone can get, or it's not indicated for every type of cancer. But if you have abdominal pain, especially pancreatic cancer, this can be especially helpful, particularly helpful. The celiac plexus is a bundle of nerves that sits in front of your spine around your aorta. It sends and receives pain signals from a lot of your visceral organs, so a lot of your abdominal organs. And if you're having pain in any of those areas, blocking that pain, that nerve plexus by injecting alcohol, which will deaden the nerve, can really greatly reduce your pain. It may not necessarily take away your pain completely, but it might take it away by 70 to 80%, which can often improve a lot of patients' quality of life. So something to just keep in mind, not all pain conditions can be treated with a nerve block. And this isn't the only nerve block that exists for cancer patients, but just know that it's worth talking to somebody, a specialist, to see if there are any nerve blocks that might be possible for your specific type of pain. And then another option is tumor ablation. So this can be done on bone tumors, can be done on lung tumors if you have metastatic lesions there, can be done on liver lesions, usually done by our interventional radiology colleagues. And I wanted to move on to complementary and alternative therapies because this often comes up too. I'm a big fan of complementary therapies as a part of your toolbox to help you heal and feel better. And if it helps and doesn't have any detrimental effects, I'm all for it. So many patients will look to try meditation or mindfulness-based stress reduction techniques. There's also acupuncture. I'm asked about this a lot. Many patients use acupuncture when they have active cancer. They often use them for any chronic pain states like neuropathy or chronic post-surgical pain. And then virtual reality has been increasingly utilized both in acute pain for procedural indications as a form of distraction, but it's also been used for chronic pain too. And there are programs out there that help patients improve their mobility through some of these exercises that can be done through virtual reality. And finally, I get a lot of questions about medical cannabis and CBD products, so I wanted to just touch on that a little bit. So this graph or this chart comes from, I think, just a couple of years ago. 37 states and the District of Columbia currently allow for the medical use of cannabis. However, from a federal level, it's still considered a Schedule I substance, which means that it's still technically illegal from the federally regulated. It's not legal. In California, we are, it's easily accessible. I'm sure as you've seen all the dispensaries. It is medically legal and recreationally legal. Data shows that about 30% of cancer patients use some form of CBD and THC products. I would say that here, my patient population in Los Angeles is more around 50%. Some patients will say that they prefer to substitute THC or CBD over opioids because of their concerns of opioid epidemic. But just please know that THC and cannabis has their own risks. Not everyone's experience with marijuana is going to be pleasant. It can leave some patients feeling really anxious, afraid, or panicked, or paranoid, and it can affect attention and memory. And just one thing to keep in mind, really high doses can interfere and possibly inhibit liver enzymes. So if you are using cannabis, please make sure that you tell your healthcare team and so they're aware of everything that you're using. So I'm sure a lot of you feel like you're a walking pharmacy. There's so many medications. I would say that many of my patients previously didn't have a lot of health issues. And once they get a diagnosis of cancer, now they're spending most of their time at doctor's offices. They're being prescribed a lot of different medications. And sometimes not a lot of guidance is given what's safe or unsafe to take together. So a good rule of thumb that I like to tell my patients is that if you have any sedating medications, make sure you separate them by at least an hour. So this includes any opioids. Most of the nerve medications can cause some drowsiness, so gabapentin, Lyrica, any of the TCAs like amitriptyline or nortriptyline that we talked about. If you're on any benzodiazepines, so sometimes people are on benzodiazepines for anxiety. If you're on Xanax, sometimes Ativan is prescribed for nausea. If you're on that, make sure you're separating that out with any sedating medications by at least an hour. And also in this category includes any cannabis products. CBD, THC, anything should be separated out by your other sedating medications by at least an hour. Okay, I wanted to switch gears a little bit. What are some reasons why you may not receive adequate treatment for your cancer pain. And I like to divide this into 3 different categories. There are patient barriers, clinician barriers, and institutional barriers. Sometimes patients' attitudes can be a barrier to receiving adequate pain management. In some cases, patients are very reluctant to mention their pain. They might be worried that having more pain means that the cancer is worsening. But like I mentioned earlier, there's definitely instances where there's non-malignant pain in my cancer patients, and not all pain means that the cancer is getting worse or even related to cancer. Some patients may feel that good patients don't complain, and if they complain, then their physicians and their care team might think badly of them. There's the fear of addiction. So there's been a lot of media attention on the opioid epidemic. There's been a lot of accidental overdoses from fentanyl. When people hear about a fentanyl patch for cancer pain, a lot of people just don't even want to try it because of the word fentanyl, not knowing that the fentanyl that's used in these illicit street drugs is not the same as a FDA regulated transdermal patch that has gone through a lot of testing. Associations with methadone, and methadone clinics being only for heroin addicts. I don't want to be labeled as an addict if I'm on methadone. And morphine is a really old medication, one of our oldest opioid medications. So, some of my older patients associate morphine only for end of life, not knowing that, morphine is actually a great medication for pain, and often more affordable if you run into other insurance barriers. Fear of side effects, we previously talked about constipation being one of them. People might not want to try pain medications if they had a really bad experience with constipation or nausea or drowsiness with any of these medications. And patients might be afraid to use strong medications too soon. So some people feel that using strong medications may mean that they might develop tolerance to these medications. There won't be anything to use from them later on. But I just want to mention that cancer pain, as you may have experienced, is really dynamic. It changes a lot. And so I think what's important is to really focus on managing your pain effectively when you have it, especially if you have severe pain. That being said, if you don't have very severe pain, you shouldn't use very strong pain medications. But if you have severe pain that's affecting your quality of life, we don't want people to shy away from using medications that are available to them. The next category is clinicians' attitudes as a barrier to potential good pain management. Sometimes your doctors might be reluctant to ask about your pain because they are uncomfortable with it, or they want to focus on other parts of cancer care. In general, I would say that when it comes to pain medication or opioid medications, my patients are most worried about constipation. Most clinicians are most worried about respiratory depression and the risk of overdose. And sometimes they may shy away from talking about your pain or prescribing medications because of this concern. Some physicians may not believe the patient's report of their pain, but remember, pain is subjective. It is whatever you say it is, and it should be believed. It can be really hard sometimes if imaging doesn't necessarily match with what you're describing your pain as, but it's important to share what you're really feeling. And if your pain is not controlled, let your team know. Some physicians may not necessarily prescribe pain medications, because they may not be as familiar with the difference between tolerance, dependence, and addiction. So I wanted to just spend a couple minutes to talk about the difference between these 3 things. Tolerance is when you are using the same amount of medication over time, and nothing else changes in your clinical history, but you notice that the pain medication isn't working as well as it was before, and you need a slightly higher dose. That usually means that your body is developing tolerance to the medication. Dependence on opioid medication means that your body is depending on these medications, and if you don't have them, you're going to experience withdrawal. And for all patients, as we come down on their medications, if their pain is well controlled, they may experience some level of withdrawal, but that level of withdrawal is very different, and there's definitely medications that help with that kind of symptoms. And then addiction is what everyone always refers to when they talk about risks of these medications. But addiction is really a psychiatric illness. It's when people are using pain medications or opioid medications, not for the purpose of pain, but for treating something else. Whether it's they're getting high from it or treating another symptom, like they're treating their anxiety with opioids. And when you're using it, continuing to use it, even when it is affecting your relationships or your work, that's what the psychiatric definition of addiction is. And then some doctors may have the misconception that opioids shorten life, and they really, don't prescribe opioids or don't prescribe enough opioids because they're concerned about that. But we know that that's not true. Opioids do not shorten life. It can help with severe cancer-related pain and really improve your quality of life. And this last category is on institutional barriers. So, sometimes these managing pain can be challenging, not outside of the patient and clinician aspect. Pain management might have a low priority for reimbursement. And I think the biggest one right now is this third and fourth point. I'm sure you guys have, if you haven't experienced it yourself, you might know somebody, but everything needs a prior authorization from insurance now, and that takes time. And then even if that's approved, sometimes finding pharmacies that carry the medications, finding medications that aren't back ordered, working with a manufacturer to supply these medications can be really challenging. So that, with these stronger opioid medications, it can be really challenging from multiple different perspectives to get patients the medications that they need. So how can you help your healthcare team understand your pain? I always recommend my patients to keep a pain diary. The couple components that I tell them to make sure that they have is the severity of their pain, using a scale of 0 to 10. So pain, like we mentioned, is subjective. So my level 6 of pain is going to be different than your level 6 of pain. But within the same individual, it's usually relatively consistent with what your 6 feels like to you. Use a few adjectives to describe your pain. Is it stabbing? Is it throbbing? What does it feel like? Where are you experiencing the pain? And aggravating and alleviating factors, which means what makes it worse, what makes it better, and what pain relief measures you used at that time and whether it helped or not. You can share this pain diary with your team, and it will really give them a better idea of what kind of pain, what category of pain they're treating, and whether or not they need to change any of your pain medications or refer you to someone who might be able to help with a procedure. The last concept I wanted to introduce is this concept of total pain. So there are many different types of pain that can keep us from living our lives fully. Physical pain is what we've really been focused on, but it's just one of them. Others include social pain, spiritual pain, and psychological pain. Social pain is the loss of your role and your social status. Could be the pain of losing your job, having financial concerns, having worries about the future for your family, loss of your independence, becoming more dependent on people around you. Psychological pain is anxiety, things like anxiety, fear of suffering, depression. If you have any past experiences of illnesses or trauma, that can really factor into psychological pain. Then there's spiritual or existential pain, anger at fate, anger with God, maybe loss of faith, finding meaning, or just having a fear of the unknown. So what all of these have in common is that they can be really debilitating, especially if for some reason we're not able to deal with them effectively. And, we tend to think of pain as just all physiologic or physical. By identifying some physical source of pain, such as the tumor, we can address the pain through radiation, medications, or other therapies. But cancer, as you all know, is a really complex diagnosis that causes distress at multiple levels. So all these domains can interact with one another, and it can make pain a very complicated symptom to treat, which is why good comprehensive cancer treatment is really a team effort. So working together with your healthcare team to address cancer pain. Discuss your pain with your doctor and your healthcare team. Set a goal and monitor your progress by keeping a pain diary, and remain in close communication. Be flexible about any modifications to the plan. Remember, your pain plan is going to look different from somebody else's, even if you have the same type of cancer. If your pain doesn't improve or it gets worse, don't be afraid to ask for a referral to a pain specialist or a palliative care specialist who specializes in specifically just dealing with pain and symptom management. And remember, cancer care is a team effort. And some of the key takeaways as we wrap up, your pain can be managed. Remember, controlling your pain is part of cancer treatment. Make sure you talk openly and share information with your doctor and healthcare team. And this includes using any sort of supplements, using CBD, all of those things, even if they're not prescribed medication, make sure that your doctor and your healthcare team knows about it. The best way to control pain is to stop it from starting or keep it from getting worse. And there are different ways that we can do that with managing your medications. And again, keep a pain diary. Share it with your team. Take your medications as directed. Like these opioid medications, don't just adjust them by yourself. Don't double the dose, triple the dose without talking it over with your team. Don't save them for later, for a rainy day or when your pain gets worse. If your pain is that severe now, make sure that you're using all the tools in your toolbox to help manage your pain. And remember, there are many different medications and procedures that can help control your pain. And this last point is just something that we've talked about over and over again. Your pain plan is going to look different, and it should look different because everyone's pain is different. Okay, I'm going to stop there and open it up for questions.